Good evening, everyone. Welcome to the IPNA Endorsed Webmaster Series 2020. It's a quick recap of pediatric nephrology, and we have now entered into the webinar 17, and we'll be spanning till December 26th. Today, we have two eminent speakers, Dr. Rupesh and Dr. Sidharth Sethi, and they'll be discussing all about hemolytic uremic syndrome. And Dr. Rupesh is the moderator of the day.
Thank you, Dr.
Rupesh.
Go ahead.
I'll just have a brief introduction, sir. Dr. Rupesh Raina is adult pediatric kidney disease and hypertension nephrologist at Akron Children's Hospital and Akron General Medical Center at Cleveland Clinic Foundation. He is also associate professor at NeoMed Medical University and Case Western Reserve University, Cleveland. He serves as a pediatric educational committee member for the International Society of Nephrology. He is a fellow of National Kidney Foundation as well as American Society of Nephrology. He serves the National Kidney Foundation of NKF. His special interest is towards transition of adolescent with chronic renal disease to adulthood. He has got a special interest in renal replacement therapy as well. So Dr. Rupesh Raina will be moderating the session for the day along with Dr. Sidharth Sethi. Over to Dr. Rupesh Raina.
Thank you, Dr. Ganeshan. Thanks a lot. And good evening to everybody in India, and good morning to the people in the US. Sorry, there was a little bit change in the time because we kind of went 1 hour back because of our fall time. So I don't think that Sidharth needs any introduction because Sidharth has been very well known, one of the best academicians that I have come across during my career. I know Sidharth for almost going back to around 8 years now. Friend, intellectual stimulator, like he brings ideas put into action. He's the epitome of medical knowledge, very, very fascinated with his cutting edge knowledge, his area of research. And he overall, apart from being an academician, a researcher, he's a very nice person and very committed to his patients. And actually, sometime I have to say that I learned from him when I discuss the clinical scenario. Sidharth has been trained in one of the very prestigious institute in in India, which is in America, the AIMS, All India Institute of Medical Science, which I think the top 50 people in the country go. So I put that AIMS equal to 1,000 times of Harvard. And I did my medicine for a year there too. And after that, Sidharth has been trained all around the country and also all around the world. He was also an ISN trainee, and he has also rotated and did observership and then was a visiting professor in our institute. Sidharth and I have collaborated a lot in the field of AKI, in the field of RRT and atypical HUS, which is an evolving trend. I'm not going to do the thorough presentation. I don't want to steal the thunder from Sidharth, and he's going to talk more about it. But definitely I have learned atypical HUS during my time after I was graduating as a fellow, and a lot of changes, a lot of new paradigm has developed, the algorithm has developed. Sidharth and I have worked very closely on atypical HUS. To an extent, we had a patient who was admitted in Medanta, and that's the first time we orchestrated to give Equalizumab in India with the patients with the atypical HUS. So I won't take much of the time, and thank you again for joining us, because weekend is very precious for all of you. But I think this talk will be very enlightening for the developing country or the country which has a very limited resource of Equalizumab. We are fortunate to have Equalizumab, but again, in our country also, it is really a tough job to get Equalizumab on board when needed, because there are a lot of the hoops that we have to cross. It's an expensive medicine. So it's kind of a nice blend at the discussion that we'll come across to talk about how you can manage typical HUS and how you manage. But the algorithm is well defined, and people are identifying atypical HUS more earlier than it was around 7 years ago. Recent literatures have been very well developed in Europe. We have done a lot of work in atypical HUS, and recently Sidharth and I are working on looking into the paradigm or validating the biomarkers, which is also a new trend for atypical HUS. I also want to thank Linda Burke. Linda Burke is the CEO of the Atypical HUS Alliance, and Linda is the rock star. She has really taken the word of atypical HUS into the world map. And Linda Burke was very generous enough to put this IPNA webinar in the Atypical HUS platform, so you are visible more all around the world. And she's a good advocate of atypical HUS, and I have learned through Linda a lot of new advances that is happening around the world. With that, I will give the podium to Sidharth, and also want to thank Dr. Ganeshan. She's really a very orchestrated and put everything in the time at the right way, because that's very hard to coordinate when you are in a different time zone. So thank you, Dr. Ganeshan, for the initiative, and then I will give it to Dr. Sidharth Sethi. And as I said, Sidharth doesn't need any introduction, and only I can say a good friend. I will also say that he's a mentor too for me in some of the studies. And overall, Sidharth has a very good heart, and he lives for his patients, and that I learn with him every day. With that, I'll give it to Dr. Sethi.
Thank you. Thank you, Dr. Rupesh, for your kind introduction. And before we start, I would like to thank especially Dr. Namalwar, Dr. Ganeshan for inviting me for this talk. And over the next few minutes, what I'll be doing is I'll be sharing with you the atypical HUS story, and I'll be sharing with you how we went from a country where even genetics was not done 2 decades back, and now where we are. So I'll be discussing 3 clinical cases which we saw over the last 2 decades, and these are real life clinical cases. And I'll be showing and discussing the hemolytic uremic syndrome along with that. So first, talking about what's the etiology of acute kidney injury, especially in South Asia and India. So if we look at over the last few decades, initially diarrhea and diarrhea-related acute tubular necrosis was the most common cause of acute kidney injury. But over the last almost 3 decades, we are seeing more and more of hemolytic uremic syndrome as the most common cause of AKI and infection-associated ATN. So as you can see here on the slide, that infection-associated acute tubular necrosis and hemolytic uremic syndrome are in fact the most common cause of AKI in children in our country, as compared to glomerulonephritis and obstructive causes, which are rare causes. I'll be sharing with you, and half of you are aware about this, that we initiated, along with the support from IPNA and the Pre-CRRT Foundation, the SARC Pediatric AKI database. I'm thankful to Dr. Rupesh for helping in this study. And the only inclusion criteria here was a child who requires dialysis, a child with AKI who requires dialysis. Since there's not even a single study looking at the epidemiology of the AKI in this part of the Asia. And all the flags which you can see, most of them are part of this study. And we just started last year in September 2019, and I can share with you that now we have more than 100 children entered who require dialysis, and Myanmar, Pakistan, India, Bangladesh, we have entries from almost all of them. And again, the most common cause of AKI in this part of the world is hemolytic uremic syndrome. And as you can see, some 1s and 2s, these are infection-associated ATN in these children. So hemolytic uremic syndrome appears to be a very important cause of acute kidney injury in this part. So I'll share with you the first case of the day. And this case was way back when I was a fellow, a 7-month-old child who came to us with a history of fever, dysentery, and gross hematuria for the last 2 weeks. So he had a history of fever, dysentery, and gross hematuria. Now on investigations, he had high blood urea serum creatinine, he had a high degree of azotemia with a classic microangiopathic hemolytic anemia. He had cystocytes more than 5% on his peripheral smear, severe thrombocytopenia, reticulocytosis, high LDH. So it was clearly a case of hemolytic uremic syndrome, no doubt about that. But since it was a 7-month-old child, we got his complement assay. So especially infants, smaller children, whether they have a history of dysentery, diarrhea or not, we should still look for their complement assay. And if you look at this child, he had low C3. It was very low. If you look at the normal range here, it was very, very low C3s. And he also had low factor H and factor B antigen, reflecting that there was a consumption of these antigens. So there was an accelerated alternative complement cascade. Now, when we looked at his parents, even his parents had low factor H antigen. So it looked like an autosomal recessive factor H deficiency. And on the mutation analysis, this child was found to have a homozygous deletion in the factor H, which was previously reported as well. So in fact, this was the first time that we had a mutation discovered in our country, because we had to collaborate with other people all across the world. It was not done at that time. Complement activation is known not only in hemolytic uremic syndrome. There are many other renal disorders in which complement activation is known. So as you can see in the slide here, if you look at immune complex deposition, dysregulated alternative complement cascade, where we'll be concentrated today, we'll be talking about atypical hemolytic uremic syndrome, C3 glomerulopathies, and so on. So it's important to remember that complement activation is also known in other renal disorders as well. Today, we will concentrate here to the alternative pathway. And factor H is the main regulator of the alternative pathway. So what factor H actually does is, as you know, that from C3, we get the C3b, and later we get the membrane attack complex. Now, factor H, in fact, blocks the formation of C3 convertase. So it's a regulator of the alternative complement cascade. So if it's not there, or it's not able to function, there is accelerated alternative complement cascade. Factor H is also a cofactor for the cleavage of C3b to inactivated C3b. So in a way, again, it regulates the alternative complement cascade by acting as a cofactor for factor I. All of you as pediatricians and pediatric nephrologists need to know factor H structure. It has 20 short consensus repeats. It has a regulatory domain where it binds to the C3b, and it has a cell surface domain. And like I said, that complement is known to be activated in many other disorders, even in C3 glomerulopathy. I remember when I joined my practice almost a decade back, this was the first child who came to my clinic. And the history was, sir, we have a child who has nephrotic syndrome. His sister also has nephrotic syndrome. Father has underwent a kidney transplant. His grandfather died of renal failure. And all of them had low C3s. All of them had low C3s. We did a kidney biopsy of the child, since this child was a steroid-resistant nephrotic syndrome. And the biopsy showed C3 glomerulonephritis with some evidence of dense deposit as well. So we found in that family a novel CFHR deletion along with a special dimerization. So as you can see here, that what's the difference between AHUS and C3 glomerulopathy? Dimerization. When we look at children with HUS who have HUS because of dimerization, this red is factor H. So factor H is always a part of that dimer. On the other hand, in C3 glomerulonephritis and dense deposit disease, they have dimerization of the CFHR related genes. And we could isolate a novel octopus-like CFHR hybrid, which could compete with factor H and causing accelerated complement cascade. Now, you can question me and ask me, why would a child get AHUS? On the other hand, when factor H is also implicated in C3 glomerulopathy, why? So there is a difference between why would a patient get which disorder. Now, the mutations which affect a child and cause hemolytic uremic syndrome, they impair the cell surface protection domain. So they are at the C terminal. On the other hand, in C3 glomerulopathies, they are usually in the N terminal. Now, I told you about the recombinations. When you have a HUS because of recombinations, it usually involves a CFH gene. On the other hand, recombinations of C3 glomerulopathies implicate CFHR genes, which are some genes related to complement factor H. So they are related and very close to the complement factor H. We'll be talking about anti-factor H autoantibodies today, and even they are also different. You can have a patient who has hemolytic uremic syndrome, but those antibodies are of high affinity. They bind to the C-terminal, while the C3 glomerulopathies mutations, they bind to the N-terminal. If you have a C3 glomerulopathy because of autoantibodies, it binds to the N-terminal. And look for complement activation in many other disorders. I remember a child, which we published last month in Pediatric Nephrology, a child who came to us from Nepal and had a dialysis-dependent posi-immune crescentic GN. So on your screen, you can see a crescent. So this child was on dialysis, was on plasmapheresis, since he had cellular crescentic GN requiring dialysis. And during the course of his illness, during the hospitalization, he got hemolytic uremic syndrome because of activation of the alternative complement cascade. And later on, we found that even this child had anti-factor H antibodies. So in fact, initially, as you can see here, these yellow arrows are plasmapheresis with albumin. So initially we were doing plasmapheresis with albumin, and LDH started rising, platelets started falling. And then when we started replacing this child with plasma, when we started doing plasmapheresis with FFP, with fresh frozen plasma, platelets started picking up, LDH improved. And later on, we could find that this child had an inherent predisposition for having AHUS. Complement is even activated in Shiga toxin-associated HUS. This is an elegant paper from Dr. Thurman, published in CJSN, where they found that when a patient gets hemolytic uremic syndrome related to Shiga toxin, when he's sick, the terminal complement products, the complement products of the terminal complement pathway are high. And when this child improves, the levels of these terminal complement cascade, looking at the soluble C5b to 9 and the factor BB, they reduce when he's improving. So again, remember that complement can even be activated in Shiga-associated HUS. And there is some evidence that patients who have very severe Shiga HUS with CNS involvement, with heart involvement, may benefit with complement blockade. And in fact, Shiga binds to factor H, and it also activates factor H. So again, this is a study which shows that the levels of Shiga toxin on in vitro studies are positively correlating with the terminal complement cascade products. So remember that Shiga toxin binds to factor H, it activates complement, and in fact, Shiga toxin binds to the same surface recognition domain of C3b. So even remember that there is a way by which Shiga toxin attacks and causes endothelial injury. Again, it's related to the alternative complement cascade. Now, way back in 2006, the European Pediatric Research Group, they looked at what are the causes of hemolytic uremic syndrome in children. Again, even in Europe, the most common cause of hemolytic uremic syndrome was diarrhea, STEC infection causing HUS. And when they looked at what are the other causes of HUS in their part of the world, still 90 out of 150, they could not find the cause. So remember that we don't know the causes of, say, around 30% of HUS. Now, in the non-diarrheal, the most common etiology is complement disorders, then strep pneumonia associated HUS, and rare TTP associated illnesses in children. So remember that hemolytic uremic syndrome, when we talk about complement in atypical hemolytic uremic syndrome, it's related to either a loss of function mutation of complement factor H, complement factor I, MCP, thrombomodulin, or in a way an antibody to factor H, binding to factor H. Or it can also be because of a gain of function mutation. So there are some activator mutations of C3 or complement factor B. Now, because of this, there is accelerated complement cascade, and there is soluble C5b-9 deposition on the endothelial cells, and which leads to ultimately platelet aggregation, activation, and thrombus formation, leading to a thrombotic microangiopathy specific to the kidney. Now, remember that as fellows, initially we used to think that low C3 is very important marker, since C3, as you can see on your right side, C3 is in the alternative pathway. So C3 should be consumed and it should be low in all. But remember, low C3 is only seen in around 30% of hemolytic uremic syndrome with factor H mutations. So it may be a marker, but not necessarily. It's not low in all. So remember, it's a balance. Complement system is a balance. Like I said, either you can have a gain of function mutation or a loss of function mutation of the complement regulators, leading on to hemolytic uremic syndrome. I'm sorry for a busy slide, but as you can see here, when you talk about atypical hemolytic uremic syndrome, complement factor H mutations are the most common cause of CFH and related to complement. And these are the children who go into ESRD very early, within 3 to 10 years of diagnosis. Okay, there are other causes as well, like we discussed, some rare causes like DGKE mutations, CFH, some risk haplotypes. So especially for the fellows, I would like to advise all of you to look at this review published in Lancet, where they looked at the classification of hemolytic uremic syndrome. And this is the classification from the 2016 consensus. So if you look at what are the causes of HUS, if you look below the cobalamin defect, all of this is atypical HUS. Okay, so HUS with dysregulated complement pathway, mutations, antibodies to CFH, even the DGKE HUS. So DGKE, so all of you need to remember that complement related mutations can cause atypical HUS, but now we know that there are mutations outside the complement function, outside the complement system, which can cause atypical HUS. I remember a case which was published in the Asian Journal last year, where we had a boy in our hospital, a 13-month-old boy with hemolytic uremic syndrome. He had a classic atypical hemolytic uremic syndrome, and I started him on daily plasmapheresis. Now, despite daily plasmapheresis for almost 10 to 11 sessions, he was not improving. And I work in a corporate setup, and the parents, they could not afford. Initially, we thought that he will improve early, we'll switch him on to alternative plasmapheresis. But since we had to transfer him to All India Institute of Medical Sciences, and there they shifted him to plasma infusions, and he came into remission almost after 2 months of his therapy. So it's important to realize that there are many other mutations, some rare mutations, which may not respond as beautifully as other causes of HUS. On follow-up, this child is doing excellent with a normal renal function. This child is hypertensive, and plasma infusions have been stopped in this child. So coming on to a second case, and this was a case which we saw in 2006, a child who was an 8-year-old boy who had a history of dysentery. 10 days back, he had a history of dysentery 10 days back. I'm sorry. So this child had dysentery 10 days back, and he had a classic hemolytic uremic syndrome. So coming back to this child, I think some slides are still, someone is pressing the cursor somewhere. So coming back to the second child, I think some speaker is pressing the cursor. Anyway, we'll come back here. Yeah, here I am. So this was a child. Why are the slides moving by themselves? Okay, now it's fine. So when we evaluated this child, we found that he had typical hemolytic atypical hemolytic uremic syndrome. He had very high LDH, cystocytes. He was dialysis dependent. Now, what's the diagnosis here? Now, that was a time where in 2005, Dr. Mary Agnes, and I would like to acknowledge her help for doing all the genetic work for us way back in 2000s and 2010s. So she had just discovered the anti-factor H autoantibodies in 2005. We collaborated with her and we found that this child had low C3, low factor B again, and very high titer of anti-factor H antibodies. Now, this was almost 3 months into the illness. We had already started him on plasmapheresis. He was not improving. He was not improving. And this was a time when we found that his anti-factor H antibodies were very high. So basically, we managed him with immunosuppression. Dr. Kalaivani, can I go to the next slide? Some issues with this slide. Dr. Kalaivani, can we somehow go to the next slide? And this child was managed with immunosuppression and continuation of plasmapheresis. Okay, so Dr. Kalaivani, can you?
Is that fine now?
Someone is pressing the slide. I cannot go to the next slide.
Okay.
Can you help
I
me
think
to
you
go
have
to
to
the next?
use your cursor and just click on to the next slide. Do not
I
use
am,
the
but-
arrow buttons.
Okay.
Do
I
not
am
use
trying-
the keypad at all. Just
Yeah, but it's just not. I cannot transition the slide.
I think now it's fine.
Can you help me to go to the next slide? It's just not
Yeah.
working. Can you take over and take me to the next slide?
Yeah, once again.
Yeah.
Is this your next slide, sir?
No, I need to cross over to the next slide. It seems stuck here.
I think, is it
It's
the
okay.
next slide?
Maybe, yeah.
I think this is the next slide.
Yeah. So that was the time, that first time a child who was having an anti-factor H antibody was managed with immunosuppression, because we just discovered in 2006. And after that, there were many children with anti-factor H antibodies discovered. And we published a paper in JSN in 2010 in collaboration with multiple countries from Japan, Korea, Africa, and at the same time, many other countries were also diagnosing anti-factor H antibodies. So this is a review published in JSN. And out of this 45 patients, you can see 38 were children from different parts of the world. Okay, so, and 14 were Indians. There were many other countries here. 7 were adults. And I would like to highlight here that almost all of them had GI symptoms. So it does, so just to highlight that a child with diarrhea or dysentery does not mean that it's a Shiga toxin related hemolytic uremic syndrome. You need to demonstrate that on the stools. So as you can see that almost half of them had diarrhea. 87% of them had GI symptoms. A quarter of them had pancreatitis. Half of them had some inflammation. So it is now known that almost 70% of children with AHUS experience a complement amplifying condition, which can be a diarrhea, just a URI in adults related to pregnancy. So if an adult nephrologist, we very commonly interact with adult nephrologists that even pregnancy associated HUS needs a complement evaluation. So these children, out of almost these 14 children, 3 died at that time, and there was a very bad prognosis initially when it was discovered. And it's important to remember for the residents here, for the fellows here, that children who have antibodies, they have deletions of the CFHR genes. So on your screen is a MLPA. MLPA looks for deletions. So for all the physicians who order tests in a child with hemolytic uremic syndrome, please, in addition to a clinical exome sequencing, you need to look at MLPA. This on your screen on the top is a normal CFHR genes, and on your right side, this is a genetic result of a child, a typical genetic result of a child, where you can see absent CFHR1 and absent CFHR3. Okay, so these deletions translate to antibodies. This was recently known. And these antibodies bind to the same recognition domain where C3b binds. And in a way, they compete with the factor H for binding to C3b, and they lead to the accelerated complement cascade. These antibodies, now it's known, they are high when a child is sick, they are low when a child improves. When a child goes into remission, the levels of these antibodies fall. And at that time, all across the world, people were using immunosuppression. Even way back in 2010, people had used immunosuppression from cyclophosphamide to IVIG to rituximab and mycophenolate. Now, I used to always discuss with my mentor in those days, like, if you have a patient who has very high antibodies, they also have low C3 with that. They also have a low antigenic factor H. How can I explain that? Initially, we used to think that maybe these children also have associated factor H mutation. But then we realize it's all about antibodies and the antigen complexes. So when a child with anti-factor H antibody is sick, the complement factor H and the anti-factor H complexes are high. So if you have a high complex of antigen with antibody, so you have a low antigenic factor H as well. And in addition to that, even the avidity, the affinity of these antibodies to bind to factor H is also high when this patient is sick. And the affinity reduces when a patient is not sick. And this explains low C3. Now, over the next 1 decade now, as all of us are aware that we had the Indian Prospective Hemolytic Uremic Syndrome Registry and the database. And this is the publication from KI of our group from the Indian Society of Pediatric Nephrology. And as you can see here, out of almost 250 patients, 138 patients were having antibodies to factor H. So in our country, in our part of the world, anti-factor H seems to be the cause of hemolytic uremic syndrome in almost 50 to 60% of these children. And again, febrile illness, diarrhea, dysentery seems to be a prodrome in almost half of them. And this is the study from our group, and you can see that immunosuppression. So this line is immunosuppression, and as you can see, if a child who gets a combination, this thick line is the combination therapy. So if a child gets a combination therapy of plasmapheresis with immunosuppression, their survival is much better as compared to children who do not receive this therapy. So especially for pediatricians and nephrologists managing children with AHUS, we need to, whenever you see a child, you need to look for factors which affect the disorders of complement regulation, looking at C3, factor H. In our experience, factor H, factor I, antigenic levels do not help much in the diagnosis of these children. You definitely need a genetic clinical exome or a next-gen sequencing for all of these genes. If you have a clinical suspicion of a TTP or a cobalamin defect, you can look for their disorders. You can go for homocysteine levels in disorders of cobalamin deficiency. Or if you have a patient who has a clinical suspicion of lupus related to HUS, you can work up in that direction. Now, there is an international consensus to manage first episode of AHUS, and even the international consensus now talks about first episode of HUS with Equalizumab. If it's not available, you use plasma exchanges within 24 to 48 hours of onset. Now, if it's positive for anti-factor H, you add immunosuppression. So even internationally, now in these antibodies, you add immunosuppression. Based on the severity, if a patient is very sick, you may add high-dose steroids with cyclophosphamide or rituximab. And later on, you reduce your plasmapheresis once the level of these factor H antibodies is less. Now, this is the paper, and I would refer you all to this paper of the Indian Society of Pediatric Nephrology, the consensus guidelines. And this paper also talks about our own experience of how to manage these antibodies. So again, this talks about using early plasma exchanges in every child with AHUS. But please remember that we start immunosuppression only after demonstrating that they have elevated anti-factor H antibodies. We don't straight away jump onto immunosuppression. So you need to demonstrate elevated anti-CFH antibodies. We may consider Equalizumab, however, it is not available in our country. If this patient is very sick, is not responding to plasmapheresis, and you add immunosuppression, you add prednisolone with IV cyclophosphamide pulses or rituximab. And then you taper the plasmapheresis in these patients and keep them on maintenance mycophenolate. So on maintenance mycophenolate with prednisolone, so you can keep them on mycophenolate or azathioprine with prednisolone for the next 2 months and monitor the antibodies. So it's important to monitor these antibodies every 3 to 6 months, because if the level of these antibodies is more than 1500 in the first year, it does predict relapse. So we need to manage our immunosuppression well and keep a watch on these antibodies in the next 2 years. Coming to the last case, this was a child, an American citizen this time, almost 6-7 years back. On a weekend, I got a call that there's an American child who just landed in our country. And as soon as he landed in our country, he got hemolytic uremic syndrome. And as you can see on the screen, he had platelets of 80,000, high levels of schistocytes, reticulocytosis. He was not oliguric, so he was not on dialysis. He had a urea of 100, a creatinine of 4 milligrams per deciliter. So we started him on plasmapheresis. Within 24 hours of diagnosis, we started him on daily plasmapheresis. Now, I was discussing with this child's mother that since you may afford Equalizumab, we have never used Equalizumab in our country, but you may try Equalizumab. So by that time, by the time we started thinking about Equalizumab in this child, he had attained clinical remission. So his LDH had reduced, his platelets had improved. And this was the first time in our country that we discussed and we could procure Equalizumab. And these blue arrows on your right side are Equalizumab. Once we could procure that, we gave this child every 2 weekly Equalizumab. And this child did well. However, it is, as all of you are aware, it is very difficult to procure Equalizumab. We had to go through customs, talk to the custom officers. We had to go through the Drug Controller General of India and get the Equalizumab to our institute. It was and I'm thankful to Dr. Rupesh, because since we had never used this drug, we had to, he was very helpful, and he told us how to use and how to titrate this drug. Especially for the residents, Equalizumab is a humanized monoclonal antibody made by the Alexion Pharmaceuticals, used for atypical hemolytic uremic syndrome. Now, the use of Equalizumab was first reported in the New England Journal in 2011, when they showed that 3 children on whom they started using Equalizumab, they had improvement in the platelet count, reduction of the hemolysis and all. So these children improved. Now, Equalizumab was also an important factor and was a lot in news when it was used in patients who got the E. coli 0104 outbreak in Europe. And you can see multiple countries had AHUS in Europe at that time by the E. coli. Now, these patients were sick. They had neurological symptoms. So this is the data analysis of who got Equalizumab in that outbreak. And they found that patients who were very sick, who had neurological features, they did respond. Obviously, a physician would use Equalizumab in a patient who is very sick. So the data was not very clear, but there seems to be a suggestion that a patient who has neurological symptoms of Shiga or cardiac dysfunction, or who is very sick, with demonstration of the accelerated complement cascade activation, they may do well with Equalizumab. So Equalizumab data and approval was based on these 3 studies. These 3 studies were basically patients who were resistant to plasma therapy, patients who were on clonic plasma therapy, and a retrospective review of children who were exposed to Equalizumab. And they found that in all of these 3 group of patients, there was improvement in the kidney function, improvement in the platelet count, and hemolysis. So these patients could be weaned off the plasmapheresis or the plasma therapy when they use Equalizumab. And Equalizumab was FDA approved in September 2011. So it was bench to bedside in a very minimal time. And remember that it's the only drug approved for AHUS, since we don't have very good trials till now to prove plasmapheresis works. So we need to have well-designed trials to prove which drug works. However, this company-sponsored trials did prove that Equalizumab works well. However, it is one of the world's most expensive drugs. At that time, this was the world's most expensive drug. Now there are more drugs available which are more expensive than Equalizumab. Now the dosing schedule is usually every 2 weeks. So there's an induction phase followed by a maintenance phase. So initially it's based on the weight. You give the drug, attain remission, and then put them on every 2 weekly maintenance regimen. So even the international consensus, I'll again show you the slide, talks about Equalizumab early and using Equalizumab. Now, when to withdraw Equalizumab is a question. Now, there are a few case reports, even in patients who have mutations to factor H, factor I, who have deletions, people have tried to wean off Equalizumab. It's a very difficult decision. And in the American boy I was discussing with you, he had a variant of unknown significance in his complement factor H. But since we discussed it with the family, we stopped Equalizumab in our patient. And he's completely doing well. I know him, he's gone back to America. And since last 4 years, he's doing well. Now in this report, they could stop Equalizumab. So this blue area is off Equalizumab, using urine protein creatinine ratios. However, they are not very good markers. Ideally, we need to have a marker which tells us what is the control of your alternative complement cascade. So there are studies, we are doing a review on that, whether a soluble C5b29 on the endothelial cells can tell you how good is your control, whether we should give Equalizumab every 2 weeks or every 3 weeks. It depends on your control of the complement cascade. So in our patient, we initially later on switched to every 3 weekly. So Equalizumab looks difficult. It's especially for South Asia, it's very difficult. It's almost out of question. It was just a day for me when I met an American boy who was completely insured. Otherwise, none of us is insured to afford Equalizumab. Now, there are a lot of drugs in the pipeline. So if you look at the preclinical to phase 1, you can see these are all the drugs. These are the complement blockers in the pipeline. And as you are aware that recently now Rejection, a longer acting C5, is also FDA approved. And now we are looking forward to more agents, complement agents, which can work and maybe cheaper for our part of the world. And we are excited about some of these drugs which are in phase 3, especially the oral C5a blocker, Avacopan. And I'm sure a lot of you would be invited for these studies in the near future. What about the outcomes of a child who gets AHUS? There are well-defined studies in diarrhea-related HUS that a lot of these children have hypertension, proteinuria, CKD on long term. And these children do have hypertension. I remember these 2 cases in our ICU who had hemolytic uremic syndrome, and we had to give them almost 10 antihypertensives. Whatever names we know of, this patient were almost all antihypertensives. And when we blocked the RAS system, using intravenous enalapril in this case. And in another case, when we again blocked the RAS using aliskiren and intravenous enalapril, we could improve the hypertension, the blood pressure control in these patients. So these patients do have severe hypertension. Me and Dr. Rupesh, we did a meta-analysis of all the case reports published till now of the mutations causing AHUS. And we looked at mutations reported from 2005 to 2015. And we found that in almost 150 patients, we could find almost more than 200 mutations. Again, the most common mutation on your right side was CFH, followed by CFHR deletions. And the outcomes, we found that whether you use eculizumab or plasmapheresis, the outcomes here were similar. However, we are aware when we use plasmapheresis, these patients do have issues of vascular excess, issues of infections. There have been 2 audits, one from Europe, one from India, showing that these patients do have issues of allergy and issues related to vascular excess. So things are changing with the era. We don't have how do we compare these patients? So people have compared these patients from the pre-eculizumab era, the French cohort and the Italian cohort. And all of you can see that when you used eculizumab in children, in the eculizumab era, this is patients with ESRD. So children reaching ESRD drastically reduced when they started using eculizumab instead of plasmapheresis. So maybe, when we do plasmapheresis, patients still have some ongoing complement cascade activation. So even pre-eculizumab era, patients who attained remission, who were completely doing well, still went into ESRD on 5 years. So eculizumab, whether it's children or in adults, it has been seen in fact in 3 trials that the risk of ESRD drastically reduces when we use eculizumab in children or adults. And coming lastly to the transplantation, children with complement factor mutations have a higher risk of recurrence, leaving the MCP mutations here, because MCP is a membrane bound. So the new kidney gives the new MCP to these patients. So they have a low risk of recurrence. So renal transplantation does have a high risk of recurrence in patients with complement related mutations. And especially for factor H and factor I mutations, a liver kidney transplant is preferred as compared to an isolated kidney transplant in these patients. And ideally, a donor should not be related if you have a non-Shiga related hemolytic uremic syndrome. So just to conclude, things have changed a lot in the last 2 decades. Now we have a better understanding of the pathophysiology of pediatric hemolytic uremic syndrome. Management is difficult, but the outcomes are improving with early plasmapheresis, eculizumab in the Western world. Search is on for newer agents, and we are excited to join hands and work for the betterment of treatment of this disease using newer agents, since we don't have access to eculizumab. And immunosuppression does work in a selected group of patients. So this is not the end of the road. I think we have learned a lot in the last 2 decades, and we will keep on learning about hemolytic uremic syndrome in the near future. And I thank Dr. Kalaivani and Dr. Namalwar and IPNA for giving me the opportunity to talk about my passion. Thank you so much.
Thank you so much, sir, for the excellent talk. And I think we have got few questions. Dr. Rupesh, are you there? Dr. Rupesh?
Yes. Who's there?
I think he's not here.
No, I'm here. That's some problem with the connection.
That.
Yes. So there are a lot of questions. Let's go one at a time. Nice presentation, Sidharth. I was not ignoring you. I was there, so blame me for leaving. It was just a problem with my connection. So the first question is kind of, I don't know what I need to entail with that question. A 3-year-old child presented with diarrhea since a week with left-sided peritonitis with cervical lymphadenopathy without organomegaly, with non-oliguric AKI, with TCP, I don't know what TCP means, with unconjugated hyperbilirubinemia with raised amylase and lipase to the tune of 150, with raised SGOT to the tune of 156, and ultrasound S off, sign off, probably normal kidney with raised renal echogenicity and GB edema. I don't know how to go about the case. So just a little bit insight about your questions. Don't put so much of abbreviation. It's really hard for us to read and formulate the question which we can understand. So I don't know what your abbreviations are, but I tried my best what I can. So Sidharth, you want to go about the case, and I don't think this sounds to me or smell like an atypical HUS, but I'll give the floor.
But we, in the last 10 years, we have started seeing children with acute pancreatitis who present with TTP-like illness. So maybe since the chat here talks about a patient who has high amylase lipase, pain abdomen, and a TMA-like picture. So it is well known and reported that these pancreatic enzymes may interact with the ADAM-TS and can cause a TTP-like illness. And we have done plasmapheresis in almost 3 or 4 of these cases in the last 10 years, and they responded beautifully. They don't have any mutations. It's all related to the acute pancreatitis and the pancreas-related enzymes. So these patients do help. Plasmapheresis does help these patients, and they do not need long-term plasmapheresis. I've done even genetics in those patients, and I could not find anything except acute pancreatitis as the cause of a HUS or a TMA-like picture in those patients.
So I think the question is, do you think it's an atypical HUS or this is something else? Because I'm not pretty sure that this gives me an inclination it's an atypical HUS, because the patient has left-sided peritonitis with cervical lymphadenopathy and oliguric AKI. I don't know what TCP means. Do you know, Sidharth?
No.
Okay, I don't know either. With unconjugated hyperbilirubinemia. So I think it's something, infection going on, and it could be entailed. I'm not pretty sure. One thing I'll tell you with my experience is when, and we have done that in our paper too, when you have a multi-organ involvement in the atypical HUS, it cannot be so subtle. Hypertension, they present with hypertensive urgency. I have a patient who's 4-year-old presented with PRES. And mainly the cardiac involvement is pretty intense. They present like a Takasabu, where there's a global dysfunction. They present with GI symptoms, which refer as colitis. So when you have the use of, or you consume the platelet, don't think those would be a pretty subtle. That would be very catastrophic. And it is hidden somewhere, and those presentations are catastrophic, and they're not very subtle. So I don't know what it is, but and the echogenicity of the kidneys were high with GB edema. So I don't know what GB edema means, but it looks like this is something you're dealing with, the AKI and infection. So second question is, can we get the slide? I will defer that to Sidharth. When to send on antibody level if patient has already been started on plasmapheresis?
Ideally, the antibodies have to be done before plasmapheresis. So all of you, we need to preserve the sample before any plasma is given to these patients. Of course, TTP, if you are not suspecting TTP, we don't do ADAM-TS, but still, at least you should store some blood in citrate for ADAM-TS. If you need that, later on you can look for ADAM-TS and the antibodies to ADAM-TS. So you need to preserve the sample, of course, pre-plasmapheresis. If you're done plasmapheresis, still at least look for the antibodies. Sometimes the titer has reduced, but it's not completely normalized.
The
so
next question is
pre-plasmapheresis.
Right, by Saul Gonzalez. This is exactly the question. I think he was just reading my mind. Thank you for the presentation. Starting enalapril IV for severe hypertension was considered at the beginning of AKI or after the initiation of hemodialysis? Very good question.
Of course, this patient was on all of these drugs, and was on dialysis. And I would like to tell you all that there is a fear in our minds when we start enalapril in these patients. But remember that sometimes, even in malignant hypertension, targeting the renin-angiotensin system does help in these patients. So we have done that multiple times. And in fact, using drugs, whether they are ACE inhibitors or ARPs, does help in these patients. So yes, in this child, he was on dialysis. He was on almost 10 drugs with refractory hypertension when we started using intravenous.
This is another very good question. In ideal scenario, should we go for genetic panel for all, for HUS in all? What is min recommended genes do you suggest?
So
again,
ideally,
I would request you to write the question in full sentences. It's really hard for me to abbreviate and use the abbreviation in your question. So it should be short and precise. Please spell it out. What exactly do you want? I don't want to miss the content of the question, please.
So I would take you all to the same, the Lancet algorithm. Before calling it as AHUS, please look at what are the causes of hemolytic uremic syndrome like picture. And especially in our country, malaria, dengue, look at those things as well. So once you have ruled out TTP-like illness, methylcobalamin defects, and infections, of course, these patients should go for a genetic analysis. And most of the genes are well known, these 6-7 genes. You can go for a next-gen sequencing for these patients. But nowadays in our country, the cost of NGS or clinical exam is almost the same. So you can go for the panel of genes, which I described in my talk, which is very important for telling the prognosis and even thinking about whether this HUS will recur later on. What about transplantation later on? What about the prognosis to the family, the counseling of the family? It is important. And I would add to that, if you look for an antibody, you can do an MLPA as well.
Good answer. Okay. And then very good question again. How do you manage infection-triggered HUS and the role of complement level in these cases, duration and role of plasmapheresis? Nice question.
Now, this is a tricky one because we do see a lot of infections which activate complement. And I would like to share with you all, we have seen rickettsia. We'll be reporting many of these infections in the future. We have seen rickettsial infections triggering a TMA-like picture. Of course, dengue, a severe dengue may look just like a TMA-like picture. Then you may have all of these infections. So of course, and especially looking at a strep pneumoniae associated hemolytic uremic syndrome, you need to be sure about these infections before calling it as a AHUS. Because there are conditions in which plasmapheresis is not done, especially in the strep pneumoniae hemolytic uremic syndrome.
Yeah, I think one thing you have to be very careful with this plasmapheresis and triggering. I totally agree with you. I will not, if there is any suspicion for the infection, you need to treat the primary rather than jumping into the plasmapheresis, because that just is not good anyway for the sepsis, because the data is very controversial on that. And if you do that, you'll be removing some inflammatory cytokines, which are actually protective for the patient. So yes, I agree. There's another question. Is there any magical number of serum creatine in HUS like GPM, where we should try plasmapheresis or immunosuppression, and we will consider giving up?
When do you give up? Dr. Rupesh, I'm sure you must have seen a lot of patients who are on Equalizumab and they respond, sometimes they respond late. So it's difficult to say when to give up. We are not talking about renal remission here. We initially, our endpoint for initially from changing from daily to alternate day plasmapheresis is the hematological remission. It's not the renal remission. So we initially, and in the meantime, you find the cause. If you're able to find the cause, that will help you predict whether you need to taper off the plasmapheresis or you shift to plasma infusions. I would suggest all of you to look at the algorithm, the international guidelines algorithm, as well as the ISPN algorithm, where they're beautifully told if you have a patient with antibody factor H, how to taper it off, or if you have a patient in whom you could not find any mutation, no antibodies, no mutation, how to switch them to plasma infusions and taper it off. Of course, genetics will help you to determine how to taper it off.
And we have published our paper too, where actually I'll put this question in a different format. There is in the adult literature the criteria definitions. If you have a creatinine level less than like 1.5 and platelet has been less than like 50, more than 50. So there are certain criteria to make the diagnosis rather than ruling it out. So keep that in mind. Okay. So the other question is, does thrombocytopenia is important in diagnosis or only in reduction in platelet from the baseline?
So there are patients in whom we don't see the classic triad of hemolytic uremic syndrome. Sometimes later in the course of the illness, when this child has come to us, we may not see thrombocytopenia. But however, when we make a recommendation or when we talk about generalizing the recommendation, we do have standard guidelines for that. And we do talk about platelet count less than 1.5 lakhs. But yes, you may not see the classic triad in all patients sometimes, because you are seeing those patients at different points of time.
That's true. Is there any role of kidney biopsy in atypical HUS?
Of course, sometimes when you need to tell, like we had a previous question when he talked to us about when to give up. Now, sometimes to prognosticate, when you need to know whether it's complete acute cortical necrosis of the kidneys or not. So sometimes to prognosticate, and of course, sometimes post-kidney transplant, when you see a HUS, how do you differentiate a post-transplant HUS from an AMR? Acute antibody-mediated rejection also has hemolytic uremic syndrome-like features. So we also do biopsies in post-transplant HUS because HUS can be a part of AMR to prognosticate these patients. So it does, so of course not for the diagnosis, but for counseling and prognostication. And like I said, for post-transplant cases, we definitely do a biopsy.
Next question is very interesting because I deal with that all the time. How do you differentiate between atypical HUS or HUS from sepsis?
So why don't you answer that, Dr.
Rupesh? Very, very tough question. Thank you, Manoj, for putting me on the spot on that question.
So we give it to Dr. Rupesh to answer that.
Very hard.
Probably the APTT is, can I add a suggestion?
Yes.
Probably all features of sepsis will be there as well as an atypical HUS, but the APTT, the clotting factor is not prolonged. The APTT is prolonged in sepsis, but in atypical HUS, it is not so. I'm not very sure.
Right.
Dr. Rupesh, you want to add on?
Probably in DIC picture, the APTT is prolonged, but in atypical HUS, it is not usually prolonged.
Yeah, but I think with my limited experience, most of the time what it happens is people treat that as a DIC, and then they surface out to be more or less atypical HS. Unfortunately, if you look into the case series in the children's, that's more trend than in adults. It is very hard to differentiate between HUS and sepsis because it is like totally a catastrophic presentation and people go for sepsis first. Definitely the algorithm that we have, as you can see, the involvement of, by the time you get ADMTS13 and others back, it doesn't help you. But if you have two major involvement, I think I have a slide for the criteria. If you follow that criteria, your chances of sensitivity and specificity is around 70 to 80%. But it is a challenge, and I get stuck with it because I think in the setting of sepsis, atypical HUS is the diagnosis of exclusion, because first thing is you want to treat the sepsis. And Manoj, I don't know the right answer. It's really, really hard to differentiate at an early presentation. So I'll go to the next question, which is a very, very good question. And I'll definitely defer that to Sidharth, because I don't know the answer. What measure could you prevent reoccurrence after the transplantation?
Now, first of all, you need to select a case. So if you have done a proper case selection beforehand, and so you need to find what's the native kidney disease. Now, post-transplantation HUS is again a talk, because there are so many causes of it, whether it can be a recurrence because of the native genetics or because of, say, drug-induced hemolytic syndrome, a tacrolimus-induced or a scorin-induced hemolytic uremic syndrome. So if you have a known patient, of course, you'll keep a watch on his complement assays. If possible, you'll also look at some innovative research stuff like soluble C5b29 or CH50. But if you have a patient who has a drug-induced hemolytic uremic syndrome, you cannot prevent that. It happens. And these are the patients who get hemolytic uremic syndrome secondary to drugs. And there's no way you can prevent that.
I think what Sidharth was trying to allude, and that's a very good question, first of all, because we deal with it all the time. Thank you, Dr. Brito, for asking that. Because when we present these patients to the transplant surgeons, they have the same concerns. If you have a genetic mutations on your hand, that really helps you a lot, like MCP1 and other mutations which have a lot less chances of the reoccurrence, you can push for that. Number one. Number two is about the immunosuppressions, and there's a lot of controversy that can potentiate or could suppress the atypical HUS reoccurrence. But there's nothing you can do. I think there's no role of any preemptive plasmapheresis. What we have done is, if the patients have a mutations which has a high chance of reoccurrence, luckily we have Equalizumab, and Equalizumab is getting very favorable kind of immunosuppressions too in certain centers. So we give them, but most of the patients, when their chances of getting a transplant reoccurrence is 80%, they don't move higher up in the transplant because the chances of that getting is pretty high. Plus it is confounded spectrum of a drug-induced TMA, and that just super add. So I don't know whether adding the CNIs or immunosuppressions or even given Thymo or any kind of induction modality can potentiate. It's very difficult to say, but it's a very good question. We get all the time.
And to add to that, the good news is that in our country, the most common cause is not the CFHH mutation, it's more of antibodies. And there have been recent reports of successful transplants in children who had anti-factor H antibodies. So because immunosuppression takes care of the antibodies. So I think in our country, we do have a better prognosis in these patients because the etiologies are different.
So now next question is from my another best friend from India. That's Rajiv Sinha. Rajiv, nice to get your question. Rajiv is saying, can you diagnose HUS without peripheral smear showing schistocytes? So that's one of the criteria though, but go ahead. Sidharth.
I would not. You do need a peripheral smear show schistocytes. And Dr. Rajiv, as you know, we all have a good friend who is a pathologist. And every time we see the patient, we ask him to look at the peripheral smear himself. So we do have, as nephrologists, as pediatric nephrologists, we do have good friends who are pediatric radiologists, good friends who are pathologists. So I would like him to see the smear and look at the schistocytes. So I would definitely look for schistocytes and not diagnose otherwise.
Yeah, but sometimes you can also take a smear by yourself from the blood and look at it under your microscope.
Yeah,
but that's
you're right.
Something very established criteria, Rajiv, for schistocytes. Actually, that's rule out. But again, going back to Dr. Brito's question about in the setting of sepsis, we are stuck. So the next question is experience of using hydralazine as an antihypertensive in atypical HUS.
I rarely use that. I do get children from different parts of the world who are on this drug, but I don't prefer to use that agent.
Right. I have not tried hydralazine, and I just kind of a little bit not my favorite drug for kids, because even in adult, I sway away in the setting of vasculitis, lupus, and all. But the problem with hydralazine is the rebound is an issue. Plus, you never know, it can initiate some kind of vascular vascular endothelial or some kind of release. So hydralazine, if you have no other choice, yes, you can. What I would suggest you in the setting, we have seen 2 or 3 patients with atypical HUS with breath. We generally do nicardipine and short-acting blood pressure medicine, because once you treat them, you give them Equalizumab, they plumb their blood pressure down. So I don't have much experience, but if you have no other choice, then whatever works in your...
So, yeah, not my favorite either. In fact, next week we have a transplant child who came to us from another country. He's already on hydralazine, and I'm not comfortable with hydralazine, and I have shifted him to another antihypertensive agent.
Right. You have a lot of other choices too. So this is a very good question too. How would you differentiate between compensated DIC from atypical HUS? Excellent question.
I think we already answered that. We had a question on sepsis and DIC, how to differentiate from HUS.
But she's asking about compensated DIC more down the road. So I think schistocytes is one of the criteria. And by the time you come to the level of compensated DIC, you already have your ADMTS13 back. Although in kids, I've never seen ADMTS deficiency, so I assume that it's going to be a normal. In adults, that's one of the criteria, peripheral schistocytes. And there is we have published a nice review article in the about atypical HUS, and actually in the adult we define the criteria. Some of them are serum creatinine and platelet count and multi-organ involvement. So I will highly recommend you to look at that score. But now, can you convert that to the peds? Not sure yet. And we are looking into the registry to give you the armamentarium. We are working with Christoph Lich, Arvind Bagga, Sidharth, me. We still are looking for the data. We didn't start it yet to give you some kind of a risk score to delineate these patients with atypical HUS. Next question is, how can we differentiate between atypical HUS and TTP in adult, presenting as AKI because ADM TS13 levels are expensive? So let me clarify this. TTP and atypical HUS is very different spectrum. You need to have ADM TS13 back. That's the only way you can differentiate. But I'll tell you one thing. In the setting of TTP, your neurological symptoms are pretty intense, very intense. Acuity is pretty high. And you don't see, it's TTP is a pentad, right? You see the neurological symptoms, renal failure. And that is exactly the article I was telling you that we have published. I'm happy to share that to Dr. Ganesh, and she can send it to you. There are 3 criteria you have to take into account: serum creatinine level, platelet count, and so its sensitivity specifically of that diagnostic criteria is around 92 to 94%. So I'll highly recommend you to read that, because most of the time the ADMTS13 back in our center, it takes about 72 hours. So that question has already been answered very well in the literature, and we use those criteria. So I'm happy to share. I have your email. If I'm not wrong, that's Dr. Vivek Goel. So I'll send it to you, that paper. I'll send it to Sidharth, and he can deal with you, because I think you're income company, so he can send you. But I'll highly recommend you to read that at least, because very my adult that is something I don't struggle between TTP and atypical HUS. And I'm with you. We don't wait for ADMTS13 to be back. This is another question. This is with regard to the first question. TCP is thrombocytopenia. Child also has elevated urine hemoglobin and plasma hemoglobin and LDH. Can we suspect EBV infection in this patient? EBV virus is known to cause lymphadenopathy, pancreatitis, hepatitis, gallbladder. Yeah, thank you, Dr. Chuck, for this, but ball is in your court. You're dealing with the patient. You're more than welcome to make differentials. So I don't know how much I can help you here. Your LDH is high, is kind of take you out of your haptoglobin you have to do. So I don't know what the correct answer is. You and Sidharth can talk separately about that case. So that has nothing to pertinent to the current presentation. So yes, whatever you think, you can go ahead, but I cannot guarantee you what the diagnosis is, because I'm not involved with the patient. This is a very good question. AKI in dengue and scrub typhus, how to approach? Beautiful question. Sidharth, very good question.
So it's, yeah, but
AKI in dengue and
there
scrub
are,
typhus.
yeah, but it's actually, we need to be, this is like out of the perspective of this study.
It says there Dr. Ganeshan, so I don't know whether Dr. Ganeshan is related to Kalyani or not. So you better be nice when you're answering this question.
Yeah, however, there are definite guidelines for dengue, especially in our country. And we need to manage these patients as any case of, say, dengue with AKI, or I don't think there's any relation with hemolytic uremic syndrome. And we manage them like a sick child with AKI, whether it's typhus with AKI or a dengue with AKI, or even malaria for that matter. We do, of course, take care of the fluids, avoid fluid overload, maintain the perfusion in these patients, avoiding nephrotoxins in these patients. So that would be the routine management of acute kidney injury in these children with acute kidney injury.
Yeah, but I agree with you. Dengue is kind of it's a very big confounder, and it gets very hard. I have not seen much scrub typhus here in the US, but dengue really muddy the water there right away. So next question is from our friend Azmiri, and she's saying, you really nice presentation, complicated topic and understandable way, good question and answer session. Congrats. Nice seeing you, Azmiri, and I hope you guys are doing good and dealing with the pandemic very well. So next is, does atypical HUS also have preceding history of infection, or that could be sudden without no trigger? Very good question.
So not all patients, like I showed in my presentation, not all patients have a trigger. But like I showed, even diarrhea or dysentery or even just a mild URI can be a trigger. So of course you can have a patient without any antecedent to trigger. So it can be.
So this is another question from snake bite leading to AKI often has sign and laboratory valuing mimicking atypical HUS. Should these patients be treated as atypical HUS? My answer to that is you already have a cause. And snake bite venom is not going to trigger the atypical HUS. So let me explain you, and that's another thing we looked into our paper, is these triggers, they're subtle. These deficiencies of the complements are subtle. They need viral infection the most, bacterial number 2, to trigger, to consume the platelet. So when you have infection like a snake bite or venom, and those are more not the changes occurring at the level of the complements, that level are occurring direct toxic effect, lipid peroxidations, direct effect muscles. So if you have snake bite as a manifest of the cause and you are presenting those, I will not even go to the HUS. Have you seen, Sidharth, that any kind of snake bite triggers the HUS and anything?
No. It's just maybe a disease which mimics that. It's not HUS. So in fact, again, I would emphasize, please look at the algorithms, rule out other disorders before labeling it as atypical HUS. We have all seen these patients, and even, complement is in our mind. So we do think about HUS in all of these patients, but it's important to exclude them before calling it as AHUS.
How do we need to follow up with the atypical HUS patient with immunosuppression agent to continue once antibody has come down to baseline?
Yeah, so that's a very difficult, that's a very difficult decision you have to take. I do remember one of the child who was anti-factor H antibody positive, and he went back to his state and he stopped his immunosuppression. And when he got a relapse, the relapses were so severe that that child died in that state, and I still remember that child. So it is difficult to taper off immunosuppression in these patients, but please look at the guidelines. The ISPN guidelines does talk about if he had no relapses, he is doing well over the last 2 years, the anti-FH levels have been less than 1,000, you can still think about tapering immunosuppression. It's a difficult decision when to take it. It's like stopping immunosuppression in patients who have crescentic GN. So it does, you need to make an individualized approach for every patient. But yes, you can taper and stop immunosuppression.
There is a very good article on the paper that they talked about how what are the factors that is predictable of reoccurrence if they stop even Equalizumab. So that's good. I got a note from Dr. Ganesh, and this is a nice one that I definitely want to share, that TTP hemolytic syndrome is a thrombotic microangiopathic, superficially like DIC, but distinctly differentiate. In contrast to DIC, the mechanism of thrombosis is not via the tissue factor 7A pathway. Results of blood coagulation assay and TTP HUS are normal. So this is one of the another thing keep in mind, although it's not in our differentials. But I'll be happy to share some of the key articles that we have done in HUS that's really helped you to approach the case. But thank you, Dr. Ganeshan, Dr. Kalirani, and Ganeshan for this input. This is nice. This is nice, something I learned too. What is the interval between the FFP infusion on maintenance therapy to the patient with CFH and Cf1 deficiency? I get this question a lot of time. So what do you want to say, Sidharth? You have more experience than me.
Yeah, so most of these patients, we do looking at the half-life of factor H. So in these patients, you need to keep it at least, I would say, every 10 days, 7 to 10 days, or so you need to titrate your patient again, looking at how he behaves. But mostly it's around 10 to 14 days when we keep plasma infusions.
Yeah. So I think we kind of done with the question, and I want to reiterate and go back again with some of the points. And I don't know, I can have my slide. Let me see if I can. I think I definitely want to have atypical HUS. I think if I can put that open presentation view. So I hope, can you all see this? Can you see my slide? Sorry?
Yeah, we are able to see. Yeah, we are able to visualize the slides.
You can?
Yeah, we can. We can.
So this is a very important PMA definition is, and we have modified more. You need to have thrombocytopenia, platelet count less than 150, and more than 25% decrease from baseline. You need to have a schistiocytes, or you need to have elevated LDH, or decreased haptoglobulin, or decreased hemoglobin. So either one of them, but you need to have thrombocytopenia. But you need to have any one of them associated with it. Confusion, seizures, or cerebral abnormalities, or renal impairment like elevated creatinine, decreased GFR, or elevated blood pressure, or abnormal urine analysis with generally you see hematuria and proteinuria. GI symptoms are diarrhea plus minus blood, nausea, vomiting, abdominal pain, and gastroenteritis. So this is an old algorithm, and in our paper we kind of modified more into different version. And let me see if I have that in this slide. I didn't have that, but I will be happy to share that with you guys. And one thing more, I definitely want to tell you that the outcome across the genotype. So if you look into the outcome across the genotype, if you use Equalizumab with the CFH mutations, time to resolve days is around 72, and CFHR is 5135, and MCP mutation is 16. But see the total number of patients that will involve, the mortality was almost 0%. And in mortality with the plasma exchange is ranging between 6.3 to 9.9. So that's something is an issue always you have when you deal with the patient. And this is something, another good slide is when you see the patients with diarrhea, gastroenteritis, 24%, URI or LRRTI, 18%, pregnancy associated 7%, and less frequent condition, which is unmasked from the atypical HUS, you have to be careful. This is another very nice paper about the effect of immunosuppressions, therapy on occurrence of atypical HUS syndrome in renal transplant. This is our UNOS database. So this can help you. And also some of the drugs are very important too, like this gemcitabine induced atypical HUS. So these are some of the slides that we have about the drugs and everything. Now, what was the primary efficacy endpoint is you need to have platelet count normalized more than 150, LDH should be less than upper limit of normal, and there should be 25 reduction in serum creatinine from baseline. So proportion of the patient with complete TMA response with Solaris, and it takes about 64%. So these are some of the good points that I just want to bring into the attention, and it's really a kind of a tough situation when you do that. So I just want to bring it back what the thought process is, just to re-summarize. Any other thing, Dr. Ganeshan or Dr. Sethi?
No.
Yeah, well, wish you all.
I think we have still few more questions left. I think we have still few more questions left.
I think I covered, and sorry, I have to go for the round two, but okay. After that, very nice. I have a very nice message from Dr. O.P. Mishra, and O.P. Mishra is the current president of the Indian Association of Pediatric Nephrology, and he's complimenting it very well, saying that congratulations to Dr. Sidharth and Dr. Rupesh on an interesting topic and clear answer to many questions. So nice to see Dr. Mishra, and I think that's what I have. There's no more question. With that, I want to thank Sidharth. Sidharth, thank you for giving your time on weekend, and you should also reciprocate saying to me, but you didn't say that. That's fine.
Thanks to you. I was about to. Thanks to you, Dr. Raina.
So, but thank you, Dr. Ganeshan, for bringing this topic. It is a topic of interest, a lot of controversies, things are learning and evolving, but I'll highly encourage to read some of our articles. These are pretty good, interesting articles for you to summarize and put the perspective. And thank you for all the questions. So nice to see all our friends from Bangladesh, from Calcutta, and from Benares. So I feel like I'm back home. So thank you again for all of you joining, and hope you stay safe, and wish you a very, very happy Diwali, which is a festival of lights. And may next year we'll see more prosperity, more enlightenment as compared to this year. I just want this year to just pass. That's what I want. Just want to survive. So wish you all the best, and wish you a happy Deepavali. Thank you for bringing me into the concept of atypical HUS, although Sidharth knows more than me about it. And thank you, Dr. Ganeshan, and thank you all. So we have to move on to the next presentation probably next week. Good luck for the IPNA web series. This is really amazing, and I love the interaction. That's what it counts.
Thank you so much. Thank you so much, Dr. Rupesh. Thank you so much, Dr. Sidharth. Like, I have to really thank you for bringing you together during the weekends and holding 2 hours of your time. I'm really sorry about it, but you really added a lot of value to the subject. Thank you so much.
Thank you for the invitation. Thank you,
Dr. Sidharth.
Thank you, everyone.
Thank you, Dr.
Thank you.
Bye-bye. Happy weekend. Bye.